So our next patient is Don with persistent right shoulder discomfort. He had a history of adhesive capsulitis with really limited flexion. He's got rotator cuff supraspinatus tendinosis, some degenerative labral tearing in the past. And so now he's completing some of our registry data. So it's important that we track our outcomes and learn how these biologics are working and optimize our protocols. So Don is a 64-year-old right-handed male who's been a patient in our practice for some time. And he's had bilateral shoulder injuries, most notably the right shoulder with adhesive capsulitis and supraspinatus rotator cuff tendinosis and some degenerative labral issues in the past. So he's made some great improvements, and he likes to throw football and exercise, and so this is more of a maintenance or a tune-up. And so we're going to be targeting two locations of his shoulder, his rotator cuff bursa and the posterior glenohumeral joint. And Don also has been experiencing some neck tightness and has a trapezius muscle trigger point and a taut band. So we'll also target that with some plasma to try to get that to release. And so what we're going to be doing here, if you imagine the rotator cuff is running in here, we're going to be doing an injection into the subacromial bursa, or the sheath of the supraspinatus tendon. And we'll watch our needle and the jet force kind of come along and open up some adhesions. Oftentimes there's a hyperechoic lining of this subacromial bursa where it's kind of thickened, and our needle is going to kind of open through that with the jet force of the fluid. And then secondly, we're going to target the posterior glenohumeral joint. And so if we have our shoulder with the ball in a socket, we're going to guide our needle into the posterior capsule and joint near the labrum. And then lastly, for his trapezius muscle, we're going to find a taut band and just kind of do a little needling and inject a little plasma here. Okay, done. A little cleaning here. First, I'm going to give you a little numbing shot, okay?
Okay.
Little pinch here. 3, 2, 1. You'll feel a little pressure here. So I'm going right up to the bursa, but not in it. Just above it. Little pinch at the skin. Injecting on my way out. Doing okay?
Yeah.
Good. So I'm going to go back through my little needle track. I can see where I came in. Little pinch, 3, 2, 1. Down, you'll feel a little pinch when I get in the bursa. Right about here. Doing okay?
Yeah.
Now I'm injecting my PRP, which is, again, white blood cell and red blood cell free. Feel a little pressure here. Doing okay?
Yeah.
Good. So sometimes I like to floss my needle through the bursa here to advance it across. Doing okay, Don?
Yeah. Uh-huh.
Good. Just to break up any adhesions. Now we've rotated Don where he's laying on his side with his right shoulder up. There are different ways to do the glenohumeral joint injection. This is just my favorite, just most comfortable and accurate for me. Others do it in the prone position. There's a variety of other techniques. So Don, same thing as before. I'm going to give you a little numbing shot first.
Okay.
This one's maybe a little more sensitive than the first one, but should not be bad.
Okay.
A little cleaning here. Going to give you a little pinch. 3, 2, 1. Doing okay?
Yeah.
Good. You'll feel a little pressure as I get close. It's a little harder to see the 25 gauge versus a 22. Right to the joint capsule and back out. Little pinch at the skin. And when doing the shoulder joint, I'll typically use a 22 gauge 3.5-inch spine needle. Unless, as in my prior patient, they're pretty thin, I can get away with a 22. Okay, Don, little pinch. 3, 2, 1. Doing okay?
Yes.
Okay, you'll feel a little pressure as I get into the joint. 3, 2, 1. Right here. It's okay?
Yeah.
So you can see I'm nestled right up against the labrum. If there's fluid in the joint, you can aspirate. Okay, nice flow, no resistance, color. If he had a symptomatic labrum tear, I would adjust my needle and go right into the labrum. Almost done. Little pinch. Okay. Now we've positioned Don in the prone position, and we're going to do a trigger point injection to his trapezius muscle.
That's definitely the epicenter.
Okay. And I'll be using the ultrasound, Don, to guide me as well. So for these, typically I'll palpate the trigger point, and then I'll go in a little blind, do a brief needle, and then have the ultrasound probe come on after. You'll feel a little pinch. It's just me here, Don. Okay. Little pinch. 3, 2, 1. Remember, it can twitch a little sometimes. It's okay?
Yeah.
Okay. There we go. Doing all right?
Yeah.
Can you hold this for me? I'm just going to back up a little bit, get rid of my local. Doing okay?
Yeah.
Good. Doing fine?
Mm-hmm.
Almost done. Perfect.